Welcome, everyone. My name is Talia, and I'll be your conference operator for today's national web conference titled 2010 General Surgery Coding Updates. At this time, all participants are in a listen-only mode. Later, we will conduct a question and answer session, and instructions on how to participate will follow at that time. For participants that are having difficulty joining the webinar for the 1 p.m. conference, please log on to www.joinwebinar.com and log in with the webinar ID 926-599-680. As a reminder, this call is being recorded and will be made available for purchase on audio CD, print, and electronic transcript. This audio conference has been CEU approved by the American Academy of Professional Coders. At the end of today's events, you will hear a CEU index number. You will need this index number to report your CEU to the AAPC. Please remember to stay on the line and have your pen and paper ready. I would like to now introduce your speaker for today, Terry Brame, MBA, CPC, GEN, SG, CPCH, and CPCI. Terry Brame has worked in healthcare management for over 12 years. She is a revenue cycle management consultant with expertise in a wide range of areas including evaluation and management services, surgical coding, academic practice, HIPAA privacy, and corporate compliance. Ms. Brame, welcome to the program. We are now ready to begin.
Thanks, Talia. Good morning, everybody, or afternoon, depending on where you're at. I apologize, I have a cold, so I'm going to try and speak as clearly as I can. If you have any questions, if you miss something, please feel free to ask in the question and answer period at the end. We're going to try and get through all this information in about 50 minutes so that we do have some time left. I'm expecting there will be a few questions on some of these new topics. Oh, there we go, sorry. So here's our agenda for today. We're going to go over the new consultation information for Medicare, the sequencing principles of CPT. There's a whole new type of code in the musculoskeletal section for soft tissue and bone tumor resection, new adjacent tissue transfer codes, paraesophageal hernia repair, there's a new lap sleeve gastrectomy code, rectal tumor excisions have been expanded, chemical pleural destruction for those of you with thoracic practice, wound compression and perforator vein ligation for vascular practices. So let's start with the consults. That's what is on everybody's mind right now as we're trying to figure out what to do on January 1. So this change is effective January 1, 2010. And Medicare is no longer covering inpatient or outpatient consult codes, 99201 to 99205 and 99251 to 99255. However, telehealth consultations are covered if you're engaged in any telehealth with rural areas. That it's regulatorily required through another law, and so they did retain those, but it is only for when that type of relationship is set up. And I'll tell you, at the CPT Symposium in Chicago, a number of Medicare medical directors attend, and they didn't have a lot of answers yet because the final rule came down so recently, and they really are expecting as the first few months of the year go by that we're going to be getting more information, things are going to change. Medicare is aware that this is a challenge for all of us, so don't feel like if you don't, everything isn't perfect January 1, that the auditors are going to be out to see you. This is going to be a process for everyone. So do your best, make best answers, and we'll figure it out together. So this is by payer when we're looking at non-Medicare payers, and most payers have not made any determinations. That's including your Medicare managed care contracts. Make sure to check with your Medicare managed care payers to see if they are following that rule or not. It becomes a little more difficult for them because by now that you should have a new contract with them for 2010, and in their contracts it says they're going to pay you for consults, so we're not really sure what they're going to do. The possibilities are that nobody else changes. There's a possibility that they might follow Medicare, or some payers might say that they can handle accepting either method. Start asking your payers now. We expect that There will be a lot of communiques coming out, but especially for your top payers, you might want to go ahead and start that conversation, especially if you have a good contact there. And for example, the Rhode Island Blues medical director attends Chicago, and he said that they're going to accept either method. So it's really going to be a pot of soup. We're really expecting other speakers and consultants in this arena. We're really expecting consults to probably go away within the next year or two because they're confusing. The documentation is hard. We're really expecting they're going to go the way of those inpatient follow-up consults, the confirmatory consults that we lost a couple of years ago. And so we're going to probably see them come out of CBT. All payers won't be paying them anymore. So that's not definite, but that's just our feeling. So stay tuned. And really, we're really expecting that the changes you need to make now for the Medicare, just for Medicare not covering consults and potentially some other payers or this mix, is that this is going to be a gap fix until all consults go away. So look at this as a 1 or 2 year solution and not permanent change. Medicare secondary, Medicare again confirmed that they are not paying for any consults, and so you will have to rebill Medicare. In those instances where you have Medicare secondary, you might want to talk. Those are some good times to talk with primary payers as well. See if how they're going to do their what they're going to accept, and see how that'll work. But do expect you'll have to be doing some rebills to Medicare. Medicare outpatient consults. So the consult requirements don't need to be met anymore. There's a little bit of confusion about that because there's a lot of talk of crosswalking the consult codes over to new and established outpatient visits. And it's not that first you have to meet the consult requirements and then you pick a new code. The consult concept doesn't exist for Medicare anymore. So based on that patient's status with the practice, if they are new or if they are established, and then based on documentation, you're going to bill the appropriate new or established patient code, and that's it. Now, if it meets the documentation requirements for a consult in the outpatient setting and it's a new patient, it's pretty much going to crosswalk 1-to-1. If it was a 99243, then it's going to be 99203. However, keep in mind, if your surgeons bill based on time, the time requirements for outpatient consults are higher than new patients. And for established patients. So if you're billing based on time, make sure to crosswalk appropriately because you're going to probably be able to bump up a level. Inpatient consults